In the advanced life support, there are generally two types of patients that are covered within this course. Either the patient is in cardiac arrest, where we address it using the universal algorithm for cardiac arrest, or the patient has a pulse but is unstable. And this is the lecture on the universal algorithm used for patients who are unstable but is perfusing. That is, they have a pulse. Now, this situation is known commonly as the state of shock. That means that the patient is unable to maintain perfusion to the vital organs. And as a result of this, inability to maintain perfusion, which means that the circulation cannot maintain enough oxygen delivery to the tissues and cannot bring enough nutrients to the cells. The body must do something to improve this state of shock. So the body's natural compensation is to try to increase the heart rate and to increase the respiratory rate so that the circulation tries to push more oxygen. The breathing goes faster to try to bring more oxygen into the blood, and the circulation pushes more of this blood around. As a result of the sympathetic activity, there's also increased anxiety and sweating, and the peripheries will be cool because the blood will primarily be circulating around the vital organs only. The patients may have chest pain, be breathless, or have signs of heart failure. In severe situations, there may be decreased conscious levels because there's not enough perfusion to the brain, and this is seen as unconsciousness and sometimes hypotension. These patients may also be bradycardic. So these are the signs to look out for to identify that a patient is unstable. An unstable patient will have all of this, all or most of these signs. And as we go further down that list, it shows that the patient is even more severe. If they have more and more symptoms, they become more and more severe, and therefore they become more and more hard to treat. So if this is left undiagnosed, if we do not identify this early and we do not treat this early, then invariably this will further result in cardiac arrest and death. And if you remember from the previous lecture, the idea was to diagnose them before they go into cardiac arrest so that outcomes can be much better. But if they have resulted already in a cardiac arrest, then the chances of survival in these patients is much, much lower if compared to treating them while they are still unstable but not yet in cardiac arrest. So it is easier and with much higher survival outcomes to treat patients at an early stage compared to the later stages of shock or when they are already in cardiac arrest. So the role of a healthcare provider for adult in-hospital unstable perfusing patients are, number one, to diagnose early this deterioration in patient status. Identify tachycardia, look for increased heart rate, look for anxiety or decreased conscious levels, look for signs of sympathetic overactivity, breathlessness, or signs of heart failure. These are things that when we can identify early, we can treat them aggressively and they technically may become better. Once you've identified this, then it's important to alert medical emergency teams or alert the response mechanism for urgent review so that interventions can be performed then. So these initial resuscitation steps must be done by everybody to help monitor the patient better, to help support oxygenation, and to help support the circulation. Our role in these early stages are to identify the potential reversible causes leading to this deterioration. And we are going in this universal algorithm, we are going to learn a systematic method of thinking about what are the potential reversible causes of shock in these unstable patients. Once we have identified the potential reversible causes, our role now is to try to restore the vital organ function as much as possible with certain interventions. and then we should prevent recurrence of the problem so that patient continues to improve. Right. So in this situation, if the pulse is present but there are signs of shock, means that the patient is unstable, then immediately activate the emergency team, and in the meantime we should give oxygen, put the patient on a vital sign monitor, get vascular access to keep the vein open, ECG monitoring, and look for signs of instability. What are these signs of instability? This is the list. Altered mental state. If the systolic blood pressure is low, below 90, if the patient has chest pain or breathlessness, if the patient has signs of heart failure, or if the patient is excessively tachycardic, more than 150, or excessively bradycardic, less than 50. These are signs of instability and require you to initiate activation and therapy as soon as possible. Once this is done, the whole team goes and looks for reversible causes, and when we can identify the reversible causes, we can treat it. And after intervention, the role is to maintain stability and to prevent recurrence. So the common causes of instability and shock are done in a systematic way, and we must start off with the A, B, and C approach. The A is to look for a compromised airway in these patients, and we do this by looking for potential obstructed airway. The airway can be obstructed by secretions, vomitus, food, and foreign bodies. And we can recognize it by hearing for sounds, or recognizing that the patient is unable to swallow or breathing is noisy. It may be obstructed by edema, example in anaphylaxis, or in injury over the mouth, the throat, or the neck. It can be due to a structural deformity as a result of fractures of the mandible, of the maxilla, of the neck, of the hyoid bone, or so on. Or it can be a structural deformity as a result of growth or tumors. The airway can also be obstructed due to unprotected or a threatened airway, and this is seen very often when the airway reflexes are lost. When the conscious level deteriorates in patients with severe stroke or severe head injury, then they lose their airway reflexes. And when the airway reflexes are lost, the airway cannot be protected anymore. There's no gag reflex, there's no cough reflex, and any secretions in the airway has a risk of going directly into the breathing passages. The airway can be unprotected and threatened because of burns on the face and the airway, resulting in very quickly developing mucosal edema and blockage of the airway very early on. And in these situations, a definitive airway is needed very early. The interventions are to open the airway with a head tilt or a chin lift mechanism, providing suctioning if we hear secretions or we see secretions within the mouth. Very often we can try to position the patients a bit better. Some patients will be more comfortable in the sitting up position, also in a slightly head up position, so that their breathing and their secretions do not obstruct the airway. In patients where they have altered mental state, an oropharyngeal airway must be placed in, looking for the gag reflex. If there is no gag reflex, the oropharyngeal airway must stay in place. If there is a gag reflex, the oropharyngeal airway can be removed. If despite these initial actions, the airway is still compromised, where we still have abnormal sounds, breathing is obstructed, then it is time for a definitive airway, where we try to proceed very quickly for rapid sequence intubation, at the same time preparing and thinking about predicted difficult airway, or if we are not able to put in an airway at all. In summary, the first priority in these situations is to look at whether the airway is compromised, and these are the actions that we need to do in a step-by-step position. Secondly, the second common cause of instability is to deal with breathing and ventilation issues. Now, ventilation issues may be as a result of poor effort of ventilation or a low rate of breathing. Example commonly is due to opioid overdoses or muscular weaknesses resulting in poor breathing effort. There may also, on the other hand, be increased work of breathing, where patients find it very difficult to take a breath because of obstructions in the lower air passages. Example, asthma and COAD. Or patients may have impaired breathing mechanics, where they try to breathe but air cannot go in. An example is situations of pneumothorax or in open sucking chest wound. We may alternatively have a oxygenation issue, where you have a problem with exchange of oxygen and carbon dioxide in the lungs. And this is often due to a VQ mismatch, which we can identify looking at a widened arterial alveolar gap. Our interventions at this moment is to look at the work of breathing that the patient is having. Is the patient breathing slowly, breathing weakly, or is the patient having a lot of difficulty trying to breathe? That's an important assessment to make. The second assessment is to look for SpO2 and, if we can, end-tidal carbon dioxide monitoring. We have to now try to give oxygen supplementation, initially with low doses of oxygen, and very quickly stepping up based on what is their SpO2 reading. If oxygen is delivered at a high dose and still we are not able to achieve target SpO2 readings, then very quickly we have to move on to assisted ventilations with positive pressure, either using non-invasive ventilation, NIV, or intubating and giving positive pressure ventilation after endotracheal intubation. It's important, after providing initial oxygenation, to look for the reversible causes and try to intervene to improve the situation. So the priorities are, the second priorities for ventilation is to assess the work of breathing, to optimize oxygen delivery, using oxygen delivery devices, monitor them with pulse oximetry and capnography. If maximal oxygen delivery given does not achieve oxygen targets, then we need to assist with NIV or to PPV, and if the patient has suspected opioid overdoses, to consider reversible therapy like naloxone. Under C, we now have to consider problems of the circulation, and to do this well, we use an ultrasound, primarily a focused abdominal cardiac ultrasound. In the heart, we look carefully for cardiac tamponade, or which may lead to cardiogenic shock, or hypodynamic left ventricle, which results from myocardial ischemia, or an enlarged right ventricle, which suggests to us pulmonary embolism. The IVC's variability can tell us a little bit about fluid responsiveness and whether the patient will respond to fluid or not. FAST can tell us whether there's bleeding within the peritoneum or within the thoracic spaces or within the pelvis. The aorta ultrasound can show us the presence of a leaking AAA. The lung ultrasound can show us the presence of pneumothorax, or multi-site ultrasounds can try to identify for us other causes of circulatory problems, for example, deep vein thrombosis or ectopic pregnancy. So our intervention is to identify signs of shock very, very quickly, and this continuous vital sign monitoring, get large bore IV access so that we can provide fluids and blood, and if when possible, like to identify where is the cause of hemorrhage and hemorrhage control if possible. If it's external hemorrhages, then we need to control the external hemorrhage. If it's internal, we need to support the coagulation process and try to initiate processes to stop the bleeding as much as possible. Very quickly at this point, patients will benefit from a small and rapid fluid bolus, and if they continue bleeding, then they require early blood products in terms of packed cells and plasma. Patients may benefit from some amount of pressors, but we must clearly in our mind look for what are the reversible causes and identify them and act on them very quickly. Under C also, we now consider the things which are common for the advanced life support course, which are the tachyarrhythmias and the bradyarrhythmias. Now, we can identify tachyarrhythmias very easily. We notice that the patient has a heart rate of more than 150 beats per minute. And in tachyarrhythmias, there are generally two big groups of tachyarrhythmias. They may be stable tachyarrhythmias, meaning that they have a rapid heart rate, but at this moment they have no signs of instability. Their blood pressures are okay, there's good perfusion to the vital organs, they are fully conscious, they are not breathless, they have no chest pain, there's no signs of failure. Right? In this situation, we probably have time to identify the possible reversible causes, and we have time to treat them with IV medications, which take a slightly longer time. On the other hand, if they are unstable, meaning that their blood pressures are low, may be in altered state, they may be breathless, have chest pain, have signs of failure, then in these patients we really do not have that much time to treat them with IV medications. And therefore it's very important to identify whether these tachyarrhythmias can be reverted using synchronized cardioversion. Now, there are four big groups of tachyarrhythmias. The big group called the supraventricular tachyarrhythmias, which on a monitor will appear to us like a regularly beating narrow complex tachycardia. So everything that we look on the monitor that looks to us regular and the QRS complexes are narrow and the heart rate is more than 150, we consider these are the regular narrow complex tachycardias, and that group we will consider them as the SVTs. There are many arrhythmias in this group, however, the treatments are generally the same. On the other hand, you may have a narrow complex tachycardia but that's irregular in rate, and in this situation, we consider them to be either atrial fibrillation or occasionally atrial flutter. If you have a wide complex tachycardia and that's regular, then that will be treated as a VT, which is a regular VT. On the other hand, if there's a wide complex tachycardia that's irregular or showing multiple waveforms, then there's an irregular polymorphic wide complex tachycardia, and there's an irregular or a polymorphic VT. Now, in this situation, it's important to differentiate between regular VT or irregular polymorphic VT because the treatment is significantly different. If we look at the treatment for tachyarrhythmias, if they are stable, we use drugs. In a stable SVT, the primary drug of use is adenosine or verapamil. For atrial fibrillation, which is irregular narrow complex tachycardia, the drug of use is diltiazem or amiodarone or digoxin. For wide complex stable VTs, then the drug of choice would be amiodarone, whereas for wide complex irregular polymorphic VTs, the drug of choice will probably be lignocaine or magnesium or some other drugs. If they are unstable, then synchronized cardioversion must be the primary treatment, and synchronized cardioversion for a narrow complex tachycardia SVT would be an initial 70 to 120 joules, and that can escalate upwards up to 3 times. Atrial fibrillation is the arrhythmia that requires the highest energy level of them all, and therefore the initial doses are 200 joules, and we may escalate all the way up to 360 joules. VT's initial dosing is slightly higher, starting at 120, and we may escalate to about 200, whereas in irregular polymorphic VT, then we start with initial 120 and escalate to 200. It is interesting that in irregular polymorphic VTs, occasionally the defibrillator is not able to identify the synchronization, and if that's the case, then we need to unsynchronize and consider defibrillation instead. Note the big difference between stable, which is treated by drugs, and unstable, which is treated primarily by synchronized cardioversion, is the signs of instability, which are low blood pressure, altered mental state, signs of heart failure, chest pain, and breathlessness. On the other hand, instability and shock under C, a circulation problem, may be primarily due to a bradyarrhythmia, where the heart rate is significantly less than 50. If the patient is in severe bradycardia and they are unresponsive and you really cannot feel for any pulse, start CPR immediately. Do not wait for it to flatline. If you cannot feel for a pulse, the patient is in cardiac arrest. Start CPR immediately. Okay? The next priority is to identify if the patient has a pulse. The next priority is to identify the ECG rhythm, or what is the block that occurs resulting in a low heart rate. This may be primarily a block within the heart, commonly due at the AV area, or sometimes called the AV blocks or the heart blocks, or it may be due to a metabolic cause like hyperkalemia or other abnormal rhythms. Our interventions at this stage is to identify signs of shock, put the patient on monitoring, get IV access. The first drug to start is always IV atropine, 0.5 milligrams stat, and that may be repeated all the way up to a maximum of 3 milligrams. Then next, to try to improve and increase the heart rate, we can start off with either transcutaneous pacing or using an inotrope infusion, predominantly adrenaline. Where and when we can, if we identify reversible causes like hyperkalemia, then treatment of hyperkalemia will improve the very slow heart rate. Transcutaneous pacing is important and early intervention that may save lives. So in patients where we are considering transcutaneous pacing, these are the steps that we need to do. Firstly, they must be on continuous vital sign monitoring. They must have oxygen supplementation and IV access. We must explain to them their condition and obtain consent. The resuscitation team must be prepared and equipment must be there. They must be provided with sedation plus or minus pain relief. Then only we apply PADs. The next step is to set the heart rate at 60, set initial energy levels at about 30, and increase by about 10. That will depend slightly on your device. When we increase by 10, we get to a point where the electrical capture is noted on ECG. Then we check for mechanical capture by feeling for a pulse. If that is there, increase the energies by a single increment after that as a safety margin to get to a heart rate of 60. If the machine is capturing the heart and there's mechanical capture at 60 and the BP is still low despite the capture, increase that heart rate to about 70 or 80 and recheck the vital signs again. Under D, there may be possible neurological causes leading to poor instability, which may be hypoxemia, which we can identify from low SpO2 or PaO2. Patient may be in severe shock, which we identify from BP and ABG. There may be hypercarbia, high CO2. The patient may be hypoglycemic, we can check from glucose. The patient may have severe seizures, we can check for EEG, or the patient may have a severe stroke, which we identify from a CT scan. So this is the priorities in the universal algorithm for an adult perfusing patient who is stable and unstable. So post-intervention care is important to maintain a few markers. Primarily, the SpO2 must be maintained at 94 to 98%. We must maintain the MAP more than 90 mm mercury to normalize hemodynamics. This is a time for blood investigation to identify further reversible causes, including the ABG. It's a good time to get a 12-lead ECG and to identify precipitating causes and prevent recurrences. After this, documentation handover to the primary team is essential. So the role of healthcare provider in summary is to diagnose early this deterioration in patient status, to alert the emergency medical team and get an urgent review, to perform the initial resuscitation steps, to identify potential reversible causes, and to restore vital organ function. Ultimately, do not forget to prevent recurrences. This is the universal algorithm for adult unstable perfusing patients.